I think I will just put a message on the group saying that we're already there.
Yeah, you created as well the yeah, I shared it to the group, and you already created this Facebook link as well.
Yes.
I think, and I just recording now. I'm putting the thing into the YouTube as well.
Okay. There is something already going on YouTube. I don't know if Dr. Natarajan said about this.
Yeah, but this time I don't think. Yeah, Natarajan is getting in. Let me admit him here, and I think next time Natarajan is going to be sharing YouTube as well. But hi, Natarajan. How are you doing? Everything's fine? I can't hear you. I think you have to unmute yourself.
His mic is off.
His mic is off?
And now he's unmute.
Let me try to...
Hi, Hudson. Good morning. Good morning.
Everything's all right?
Yeah, all right. My friend is using my laptop to do the live streaming. He's already set up that a software called OBS software.
Yeah.
I can see Asta Jain. She's
yes.
Yeah. The Facebook.
She just finished authoring a good book on textbook of veterinary surgery with Springer.
Yeah, that's
gone to the editorial team, sir.
Pardon?
It's gone to the editorial team for the final review, sir.
Yeah, and I think we can make Hudson do the next book.
Wow, that would be an honor for me.
Asta is actually tired working with me on this because contacting authors all over the world.
So, sir, it's not been tiring. It's actually been very exciting, I would say.
Good. No, I know. Yeah. It is.
This is the time to do that. We don't know how long it's going to last. You know, this COVID times thing. And we have to relate to each other and try to do our best to approach. So it's time to do that, you know. I think this is a very good idea.
Yes.
And
I just made an introductory video and I posted in the YouTube.
I saw that, sir. Aishwarya posted a link on the WhatsApp group.
Yeah. So even Hudson would have said it's in the group. I just finished the video introducing you, Hudson.
Yeah, thank you very much. And I saw you sent the video.
Hello, actually, we are all there. You can join the Zoom.
Yeah, I'm joining. Yes. Yeah.
And also, I'm sharing that. I'm gonna put on the chat. I'm sharing via YouTube as well through the channel Retina also.
Okay, very good.
When the meeting gets known, we're gonna be sharing with more people.
Yes.
Sometimes people are not used yet to the links and things, but I will share now with more residents as well.
Right.
So, Trajan, how is the perspective? How are people thinking about the COVID patients and everything else?
Now, what is your question regarding COVID patients?
Yeah, you are getting to see more patients by now.
Yeah, it is very slow. They are getting a little more. Yes, today also I went to the operation theater. Today or yesterday also. And again Friday I'm operating. And the outpatient, Dr. Asta, all of the other doctors are doing. I do few. And the other we have about 12 consultants. And then 2 consultants a day are coming. Staff also are 1/10.
Yeah.
Anil, are you ready?
You gotta be
Yeah.
careful.
I know. You'll be ready, but he's also doing something to do in the other channels.
Okay.
Yeah, that's it.
Okay.
And so I prepared something to talk, very interesting. And whenever you want me to start, and is your link from Facebook.
Yeah, that's what my guy is waiting. Anil is waiting to start. He'll give a countdown and we'll start it. So if you keep the what do you call our Zoom screen, and then you'll also give us the recording, Dr. Hudson.
Yeah.
Okay.
Okay. So,
So you need to keep the Zoom screen on and off at all times.
Pardon?
You need to keep the Zoom screen on at all times. That is your Zoom video.
No, I didn't understand. Zoom, what do you want to do?
The Zoom screen, which is on the display, that you need to keep on at full time, not the Facebook screen. As in the video with Hudson, sir, you need to keep that one on. Like this one. Yeah, as it is. Okay.
Right. So Aishwarya has joined. Aishwarya, you're not coming on the screen?
I'll come, sir. 1 second.
Okay.
Sir.
So Hudson, you let us know we are ready to start the streaming.
Hi, Ashara.
So
we have to get used to say here it's a good morning and say good afternoon for you. And it's a pleasure to be here. And I think I'll be sharing my screen. Can you see myself here?
Hudson, can you allow me to share the screen? And then I'll introduce you and then you can start. So we have with us, welcome to I call this as a Retina master. So welcome to this video teaching. So I'm going to share my screen.
So you are the co-host now, and I will make Asha also co-host and Asta as well.
Okay.
So everybody here co-host.
So
You need to keep on this desktop, sir.
Yeah. Now we're going to be able to share your screen. Yeah. I see.
yes, okay.
We're starting to see it, but it's going on.
Oh, yes. So you can see the screen?
Yeah. Mm-hmm.
Okay. So welcome to the Retina Master YouTube channel. And that's what we have inaugurated now. Thanks to Dr. Aishwarya, who's made the YouTube ready with me, and my colleague, Mr. Oli, who's a senior optometrist, who's not here today, but he helped me yesterday. We created this YouTube. And this is my dream, long-term dream for teaching. And that's how me and Hudson are working together. So Hudson has already made another YouTube channel called Retina Awesome for the practicing vitreoretinal surgeon. And I've taken a cue from that and then clue from that and started this. So we are just starting the inaugural meeting today. So we stay tuned to the Vitreoretinal Master YouTube channel, but we are streaming this live from the through the sorry. Okay, so anyhow, we are doing the YouTube channel. So this channel is to teach vitreous and retina surgery to residents, fellows, young ophthalmologists, and all ophthalmologists interested to learn. And what we want to teach is me and at present the teachers are Hudson, but we have our consultants, Dr. I'll just let you know. So we want to teach the basic in vitreoretinal surgery, surgical videos demonstrating the skills involved in vitreous surgery, lectures on topics related to vitreoretinal surgery, recent advances and newer techniques of VR surgery. So this is our inaugural lecture series, and thanks to Hudson for putting this up. So main idea is we wanted to, during the COVID time, there were not much of patients, but at the same time, we want to keep continuing the clinical education to our ophthalmologists, or either who just joined residency, who don't know what to do, or they have a COVID posting. So this is a resident class where vitreoretinal surgery teaching through an innovative way of learning surgical basics for postgraduates and fellows. So today's topic is scleral buckling, when to do and when not to do. And we have none other than Dr. Hudson Nakamura. And we have panelists or consultants from Adytia, Dr. Jaydeep, Dr. Asta Jain, Dr. Amit Jain. And we have Dr. Adytia Rai as the fellow. So I'm happy to introduce Dr. Hudson Nakamura. He's a medical specialist in ophthalmology and specialized in retina and vitreous. He did a fellowship in vitreoretinal diseases in Toronto, Canada at the University of Toronto, and another retinal fellowship in his hometown city, Goiânia, in Brazil at the CBCO Brazilian Center for Eye Surgery. He completed a study from School of Medicine at the Federal University of Goiás, UFG, Brazil, and residency from the base hospital of the Federal District Brasilia, DF Brazil. Former attachments as member of the American Academy of Ophthalmology, Brazilian Council of Ophthalmology, Canadian Society of Ophthalmology, and also ARVO, the Association for Research in Vision and Ophthalmology, US. He's currently working as professor in Department of Retina and Vitreous course of medical residency in ophthalmology and fellowship in vitreoretinal diseases. He's also founded, together with myself, as well as others, of the Retina Awesome, which joins the retina specialists from different countries. It is 100% totally Hudson's idea, which he has done, and we are coming with the next one is on September 12th for the practicing vitreoretinal surgeons to interact and present interesting cases in vitreoretinal surgery. He has done 4 successful Retina Awesome. So today, as I said, we have Dr. Hudson Nakamura. I think, according to me, he's a dynamite and a young, energetic professor who's willing to teach. And I'm glad that finally I realized my dream of teaching. Because in between last 5 months, even though we conducted several webinars, that's all for practicing doctors. I think we did some motivational talks for young undergraduates and postgraduates, but today is the day we have started teaching, and we wish more and more speakers will be there. Already Hudson has made a schedule every Tuesday, say at 15:30, 3:30 Indian time, and so we have
7 a.m. here
and Facebook Live, and then stay tuned. So I'm stopping my screen, and over to you, Hudson. You can take over.
Sure. So it's always a pleasure to be here, and we are going to be learning together. And thanks for the introduction. Can you see my screen over there? And I will. Can you see it?
Yes.
So I guess the screen is large enough. I'm trying to get the actually a little smaller. Just a second. Let me go to PowerPoint over here. Let me share. Let me share not there. Let me share through here. I think it's better. Yeah, you can actually see the screen, the internet. Just a second. These internet things are teaching us a lot, no?
Yes.
we'll learn every day. The image was so cool that I thought it was the PowerPoint, but it was actually the internet. So I will move it down here. We have the keynote over there. Let me share again. I got it. So just a second. Play slideshow. Okay. I guess now you see my screen, no?
Yes.
Is there anything on the screen besides?
No, it's fine.
No, everything's fine. Okay. So we have our residency program here, and the thing is, we try to relate to each other more than we teach. Of course, we teach. We like teaching, but it's very important to relate because we are going to be together with our residents and fellows through the time. So we prefer to show how things work and how we could relate and make the best from our teachings. And I'm going to ask probably Asta that I made this co-host as well. If anybody gets in, you just admit them, okay, Asta? And so we are at the iBank Foundation, and I'm going to talk about Scleral buckle, doing Scleral buckle or not for retinal detachments, in vitro retinal surgery as well, and scleral buckling surgeries alone, and why we are doing that and why we should do and not do. So I presented these several times so far, but this was a meeting in 2015 in Baltimore, and we were talking about the advantages of combining surgery, the scleral buckling surgery, together with vitrectomy. But the thing is, should we be doing the surgery alone? What the indications are for the scleral buckle? Whenever you want to do the scleral buckle, if you want to do the scleral buckle alone, or if you want to do with vitrectomy. But what are indications? What the indications are for the surgery? And Natarajan knows these times because years ago, many years ago, we used to perform the scleral buckling surgeries, but with a lot more indications than we do now. But because we got to the 23, 25, and 27 gauge era, people kind of forgot to do scleral buckles, and so people prefer to go ahead and do a vitrectomy because it's easier, saves more time, and you don't have to work that much for the scleral buckle to open up and to put the band and do things. And even some services and even some people, some doctors, they counter-indicate the procedure and they go straight ahead to the vitrectomy. But we cannot forget the history inside this all. So there are all things from the past, but we still keep them working. And why we still keep them working, some of them are still hard, good, and they last, like this machine is still working. And in the past, as you see here, we did not have too much and good materials to work and do surgeries and even see the patient. So it was very difficult to record. This is fundus photography, and also this machine was able to record not anything close to what we have today, but that was a start. And today we are able, with new equipment, to see the peripheral retina, to see the retina with good stuff, good lenses, good condensing lenses. So we go up to the periphery to see all structures. And this was a paper we did in the past comparing scleral buckle and scleral buckle vitrectomy for pseudophakic and aphakic retinal detachments. This is a good indication for that. But even today, I do scleral buckle combined with vitrectomy for phakic patients as well. But when to indicate, that's the thing. This is what we had in the past. You see, we have a lot more today, more options. what we most use, we like using today, mostly is the 240 band and the 42 band, the buckle 276 tire. So we have a lot more options than we had in the past. This is a book from 1965, already showing details on the surgeries, showing many materials. And if we compare to today's time, we have a lot more options, of course. But still, even though we have so many options in today's time, people don't want to do as much buckles as we could do because of the modernity. And as I said, even some doctors, they do not indicate the procedure due to personal reasons. And I gotta tell you, in the past, Natarajan, I had a loop that I used for my buckles, but because presbyopia ensued, now I use the microscope. I see a lot better with my microscope. I see the details. I see whether we have vortex veins. I see the scleral thinnings, and we can zoom it in, zoom it out. So it's a lot better today. And basic knowledge from this buckle, for example, 276, we have the buckle measuring 7, but we gotta give the stitch a little more, 9 or 10 millimeters to get it steeper and get a good indentation. And on the top, you see 2.5 millimeters, the space, exactly the space you use for the 240 band. As you see here, yeah.
No, you mentioned about using loop. I have seen my mentor using the loop in 1984 when I did my fellowship. And that time I was telling him, you have a microscope, you're doing vitrectomy, and why do you want to use the loop for you doing the scleral buckling? So I actually started using the scleral because my passion was to do microsurgery. That's how I landed up in vitrectomy surgery in 84. And I convinced him because he was doing vitrectomy with microscope, and he'll do buckling without microscope. He'll move the microscope away and then do the Charles Skipham's implant, because he was a fellow of Skipham's and he was doing for every patient an implant, sometimes 360-degree dissection, and then you use the loop. So I told him, why can't we do the, because he said it's external surgery. I said, so what? So then I remember the squint surgeon took over for even squint surgery. He used to say, oh, I can see better. But I think it's a world of difference when you use the microscope. Then I found out in the late 60s, I think there was some publication, few people used microscope. And I know now everybody only uses microscope, which is, I think, important because apart from using indirect, I think scleral buckling, you should use a microscope so that you identify the vortex veins and also the tissue care. When I remember in 84 when we were operating, turning the eye this way, that way and the eye, next day you can't open the eye. And that's because you're pushing and pulling the eye too much. And now with the microscope, your movements are restricted and probably microfined, which I think the tissue care is better, so that the next day the eye does not look like you're operated. Go ahead.
Yeah, I think the same story. I started using the microscope. We see a lot better, but I like to show off my loop because, this is something to remember. This is so good. And it's a hassle. I have to remove it from your eyes and go back to the microscope. And so why don't you go straight to the microscope? You see better. You just have to find your way and move the eye. Maybe you have to tilt the head from the patient sideways and to find the place of the suture. But, scleral buckling surgery takes some engineering, it takes some thought and lots of patience. And not everybody today have that patience. And so that's why so many go ahead and do
this topic. We have Amit Jain, Asta Jain, and also Jaydeep, all, I think, a similar school of thought and training. They're doing independent surgeries and they're consultants. So I think we can make it interactive in between. You can ask us questions of sometimes so that for the audience and for the students, it will be interacting. And I'll also ask Aishwarya, because this is your first class. You can definitely ask your doubt because I'm addressing you as a student, but there are a lot of students world over. Maybe we are not having them directly on the Zoom, which we have to make a mechanism in future. So maybe in between, each one can either raise your hand by this way or putting in the share, what do you call, the reactions which you have, you can even raise the hand, right?
Of course, of
You
course.
don't mind. Or you can also ask a leading question to them, so they can also add their points.
Yeah, and now, yeah, it's up to you if you want to speak. And I gave them the co-host, so that's not a problem. So we are here to discuss. And as we have these drawings here, the buckle cannot be too tight, cannot be too loose. It just have to be the right way. So you have the buckle from the C is too tight. The one from the letter B is okay, and the one from letter A is kind of loose. So these things have to be thought about. And if you are combining the surgery with vitrectomy, the buccal vitrectomy, oftentimes you don't need to be so hard on the buccal to get a very high indentation. But then I will tell you the advantage of doing more or less indentation. And we have here a book from Charles Skippins. I like to show these things, Nantarajan, because people do things today, but they don't know what the thing came from. So it's good to explain and show the some history. So this book from 1965 from Charles Skippins and Reagan was showing from the Retina Foundation, Boston. You see here actually the top left figure. You see that the buckle started with the resection. We started with the sutures, and then resection over the break. They put a partial tube in instead of the silicone materials we have today, and then a circling tube with a silicone implant. And then we come up with the materials from today. There is the silicone bands, and the 240 bands, 276, and 42, and all others, and different materials that we have. And this is interesting to read. It's a comment from Dr. Skeppens. Because today we are deciding whether to do buccal or not to do buccal, or to go ahead and do vitrectomy. But in the past, there were discussions and two-step operation for retinal detachment. You guess what? They were thinking, should I be doing the buccal completely, or should I be doing the part of the buccal, and then in the other sitting, I will do another buccal. So it's interesting to read this, because Charles Keppins commented on that, saying that the best thing would be, into his comment here up above, is to do the buccal completely, and not to do partial buccal and then the other half of the surgery, because they thought by doing just the drainage, they doing just the first part, and then approaching the RPE from the sensorial retina, they could do the second part later in another sitting after the inflammation was over. So, but this thing came up with too much PVR and other complications. And I want to read something here from Dr. Skippins, because this is history. I'm less optimistic than some of the speakers about the post-operative settling of a retina when a buccal has been obtained, but the retina is not reattached at the end of the operation. It has long been known that if a break is closed with simple diathermy alone, a pocket of fluid may absorb postoperatively. In my experience, however, this does not happen in so-called unfavorable cases with much vitreous traction. This is one reason why I am not enthusiastic over the two-step method. Since the conjunctiva and Tenon's capsule are already open, the surgeon has a perfect opportunity to release subretinal fluid, thus completing the operation in one step. This is the thing, you know? And so even today, whether we decide 2020 to do buccal or vitrectomy. In 1965, they decided whether to do partial buccal or completely buccal, and this is just an example. And as I said, the same figure I showed you 5 minutes ago, showing whether you do more constriction from the buccal or less constriction of the buccal, you see here in the same book. So this has not been changed. What changed is whatever we do for more or less. But you see the same figures, whether the constriction is excessive or not, and or too loose. So this is a nice picture, and we have this updated picture here, and we know that well, the buccal should sit on the break and do a perfect indentation. Otherwise, the retina might not be attached, and you might get out of the pressure from the buccal, of the tightening of the buccal. You might get some other complications. So you gotta put the buccal on the hole or holes, and if you have them in the same lining, this is good. But you don't have them. If you don't have them in the same lining, you gotta put a radial band and the complete the buccal by doing more steps of the surgery. Then that takes longer. So that's why not very many people are interested in teaching or even doing that. This is a picture from Mayo Foundation. And here, interesting result from a very high myopia patient. You see the very good indentation. And actually, when you do vitrectomies today for very high myopes, and the eye is quite large, I wouldn't do such a indentation like that for the surgery. That's probably too much, but the outcome is good because the sclera is thinner, and therefore very high myop patients, we are allowed to do that. And we have here today the silicone band, for example, and the silicone fixation sleeve to put and tighten the buccal. But in the past, we did not have those things. We had these tantalum clips. You see, Natarajan, we did not have the silicone fixation sleeve. Well, now we have sutures, we have Mercilin, we have Dacron, we have even some people in the past, in the very not long, used nylon, but I think nylon is not very good for the eye, even though you can cover with a conj. But today, you know, in the past, they used this tantalum clip, so to hold the band in place. We don't need to do that today.
Skipens also has described a brother's knot, like a double thing in the suture, which you can use instead of the tantalum clip, and which Dr. Skipens has described in his big voluminous retinal attachment book.
Yes, and then this big suture might get some indentation as well, and hide the band of the buccal inside. So things are favorable for us with time, but it's good to watch these historical pictures, you know. And so it gives too much of work to do that, but it's still, if we had this and we had to use it, we will probably have a successful retinal detachment surgery, scleral buckling. And as you have here, drawings are very important. You have the thin line and the thin black line. You have the 240 band, that is, which is called the encircling element. We have the buccal supratemporally there, and the buccal is where the break in the retinal detachment was. Even though you have a large retinal detachment, but you have one break supratemporally, but still the patient was elective for the scleral buckling surgery. You don't actually need to do vitrectomy. If it's indicated a buccal, you put a buccal there and drain, and then you have the right positions and do whatever you have to do to close the hole, either cryotherapy or laser. I prefer today to do laser because after you drain, you have the RPE and the neurosensorial retina opposed. So you actually, the laser takes better. But if you don't have and the fluid is too much, but still you want to close the break, you might use the cryo as well. But the thing today is not to use the cryo so much because it could cause the more inflammation and PVR and things. But cryo is still a very, very good treatment. And I was reading up into this book, Natarajan. They are saying that, you know, we have good pictures. I'm not displaying here for the sake of time because there are so many pictures and good pictures to see. The surgery is actually with cryo as the only therapy, like doing the buccal, not doing the buccal, only doing cryo for everything. So quite a few cases that worked. They
But
showed
that
the
time, Hudson, I think the idea is teaching students. So I think probably we have to make a mechanism of asking questions from the students. But I hope Aishwarya will ask now, and or maybe Asta and Amit and Jaideep can add it. But I think whatever you have, I think this is the time. It's not any time constrained session. But I agree, you also have to start your work. But you can show all the pictures, and you can even divide the talk. Maybe if we can't finish today, we can continue and then postpone the second topic a week later, so that
okay,
we
okay,
have a lot of
okay.
learning. And I think I'm really amazed and I'm happy to see your old pictures, Charles Gibbons and Mayor Shukrat. Really great, because I was a second mentor with Raja Jonas, and he always told me it's very important to know history. And I always remembered from my school teacher, the history I remember as high story. And the reason is, I think Isaac Newton also mentioned, you don't have to reinvent the wheel. And I think if you are able to stall on the already the tall stalwarts in the field, you can see better and you can probably learn better. And that's the idea
Oh
I'm
yeah.
creating a platform where first student will be. Maybe Amit, you would like to add something? Amit?
Yes, sir.
So Amit is also trained in my same alma mater. Yes, yes,
Hello.
Amit.
Yeah, so scleral buckling, as everybody knows that it is now an art which is not practiced with many. However, my mentor was Dr. Mona and she taught the buckle. Buckling for me is any detachment. The first most important thing is you should be able to indent and see each and every area of the retina. That is the most important. So there's no shortcut to it. You have to indent, depress, and see the retina through indirect ophthalmoscopy. Only then you can decide for buckle or not. You cannot miss a break. That is the foremost thing. And second is, if any break is depressible, it can be buckled. That is my first. Whenever I see a RD, if it is the break is depressible, then my first option comes as a buckle. Only if there are other factors which limit the procedure as buckle, then I think of a vitrectomy with or without encephalage.
Yeah, you are right. And for me too. But because we did that paper and we saw so many patients in Toronto, Canada, patients after cataract surgery, especially pseudophakic, but some aphakic. But usually those patients, they have these very tiny, small little breaks in their very retinal periphery. So some of them deserve a combined surgery, because oftentimes you go ahead and do a buccal, but you might not see a very small break elsewhere, and the surgery may fail. And by doing the vitrectomy altogether with the scleral buckling surgery, you remove the RPE cells, you clean up the vitreous, you have the more mobile retina, you get away with tractions and doing the two things, and having the benefit of doing the buccal with the good indentation, you can do a very good surgery. But I still with you in the thought, and still doing the buckles whenever we can do, and not giving up on them. And this is this book from is still updated from
Alice
1968, yeah, a long time ago, from Alice McPherson. You see here, they are showing good things from the buccal. After you
I
do,
knew Alice McPherson well.
Yeah, yeah. The
because
right
of
place
the
to do drainage. You see the right place. If you go in the image from above, if you drain near the hole or the break, you might get the retina trapped. So if you squirt away the subretinal fluid from the detached area and towards the break, and I mean towards away from the break and towards your drainage site, the retina gets attached with no subretinal fluid, no fluid inside the vitreous, and no retinal trapping. So this is a good picture. It's updated from today. And as you see, some techniques did in the past, they drained away from the buckling procedure, as you see here. But today, in today's surgeries, as Amit Jain, I think he does that as well. We do the drainage below the buccal, but then we cover it, but not close to the hole. Isn't that, Amit?
So I have been seeing a few cases. So from last 3 years, I am doing almost 90 to 95% of my cases non-drainage when it comes to buccal. And I do believe in the process that drainage is just for our satisfaction. Many a times, there are cases where would be a very thick SRF and drainage would help in the process to retina to flatten faster. But then drainage is only for our peaceful night sleep. Whereas many a times, if you just oppose the break to the buccal and do your adhesion of the cryo or laser, whatever, in next 1 or 2 days, you will see all the SRF being drained out by the RPE pump mechanism, and drainage you don't need. So by avoiding drainage, I avoid all the complications associated with buccal. Mostly they are associated with drainage, like suprachoroidal heme or subretinal hemorrhage or retinal incarceration. So I prefer to go completely extraocular, don't go intraocular at all, except for paracentesis, just to lower the IOP when I give a tightening of the buccal.
Yeah, that's what I was going to tell you. If I had to do the surgery without draining, it's okay. If you have a shallow retinal detachment with not too much fluid, you can do that, no problem at all. But I would do at least an anterior paracentesis because you might need to tighten the band a little bit, and so the RPE bomb, as we say, it's going to work through the night, so you don't need to lose your good night, a good sleep. And then if you did the laser, and it's okay. I think it's okay. But the thing is that the reason I like doing drainage is that especially in those huge and deep retinal detachments with too much fluid, when I do the drainage, the laser, because I'm doing more laser now than cryo. If I had to do only cryo, that would be okay because I do the indentation, so I freeze the hole or the break, and so that's okay. But because I'm doing more laser, actually most of my cases I do with laser, even though if you have a round hole and it stays seated after the drainage on the buccal, you might not need to do even laser or cryo. But because I'm doing laser, I drain, and then, well, of course, my drainage is very careful because I do pretty much like they are doing on the picture there, but except for the stitch, because I put the buccal on the drainage side, so I don't need to stitch it. But then I'm extra careful not to cause any hemorrhage and things, as you said. But you have to see the choroid, and you have to open up and withdraw the sclera to see the bluish thing there, and then you do the right step. And then after doing the drainage, I do the laser. So because now the RPE is opposed to the neurosensorial retina, so it's good to do the laser. But yeah, it saves time. Also, we gotta be extra careful to find those vessels. This image is so interesting. It was drawn, but you cannot go too posterior, otherwise you might get vessels there. And it's a good way, transillumination, to see whether your your vessels are, in this case, they're showing vessels and nerves. You can see through the transillumination. And as I was showing the tantalum clips that we don't use anymore, but still ways to move the 240 band or any other band up or down. You have a broader band like a 42 for a larger break would be okay. I had a professor, Dr. Berger, in Toronto. All his buckles, he used a bit. All his buckles, he used the 240 band. It's too thin, but he used 240 band. He put the 240 band over the break there, and he would tighten a little more. He would even do more sutures, just more spaced. So you would create more indentation, but he could get away with cases by only doing the 240 band. That was awesome, and he was very good at doing that. Diathermy, opening the scleral that way. Some people still do, and there are some materials to do that. I actually personally, if I'm extra careful to drain, I use only the tip of the needle, the very tip of the 30 gauge needle, for example, after knowing that I don't have any vessel or any other bad possibility of getting a hemorrhage. But still, you can use these electrodes to go on with. These are interesting pictures. And after closing, you see the materials from years ago. These were a very good advance. Nothing compared to the ingenuity we have today, Nataraja. This is interesting to see. And this is inflammation caused by the apposition of scleral buckle towards the sclera. You see that helps and helps the buckle to stay there in place. And it's good to have the indirect to see the patients. And how many of you here do indentation? I guess everybody does indentation. And I use the indirect. I look for the break always at the very retinal periphery. But some people use the 3-mirror lens, but I might use it. But I think it's a lot easier for me to see with the indirect and see the whole periphery. And how many of you guys use this? And I would like to ask, what's her name? Aishara. You like using the indirect in
Yes,
your
sir.
service?
We use the indirect lens while examining patients. So right now, I've just recently joined my workplace, so I've not yet had the opportunity. But in my previous place, I was using indirect ophthalmoscopy, binocular examination with indentation.
Yeah, that's good. Yeah, binocular, if you get used to that, it is the best thing, And for better resolution as well, reduce the distortion. And here, many different materials we have today, very good ones without the cable, without. And the good thing is to draw. We did go to the OR, but before going to the OR to do a buckle, our teachers, Dr. Lam, Dr. Deveni from Canada, Dr. Marcos Avila here from Brazil, and other doctors elsewhere, Dr. Berger, Dr. Harvey, Dr. Mandelkorn, you had to draw it, but usually people today don't have time to draw anything. But it's good if you have a drawing. But today, everything is electronic. You go to the computer and you see everything there written. But if you have a drawing, it is so good to teach the residents. And I urge you to draw your patients in the special charts like you have here. You have to know, I was taught to draw this way. The patient is with the head up, and then you put you see the patient, 12 o'clock there, his head is pointing there, the arrow, and then the drawing is the other way around. You see 12 o'clock is in the opposite side. And whatever you see, you just draw. It's going to be right there because the lens is inverted. So you draw that way. You see here? 6,
This is
12.
from the Rosenthal article. Is this from Highlights of Ophthalmology? This pictures, Hudson?
Yeah. No, I don't know. I got it some time ago and I just put
So,
into my presentation. I think so, yeah. I think so. I think it's from Highlights of Ophthalmology.
No, so tomorrow Aishwarya is going to come to the hospital and every fellow in our Adytia gets a printout of this 30 pages article as well as in the fellow's manual. And every consulting room has a set of color pencils and a drawing.
Yeah. Yeah, we have to have, the thing is that nobody has the pencils anymore. They think these things are from the past, but they are not. Natarajan, you know that I don't know very many people that do that, but I do inverted vitrectomy. But by the time I'm there with the patient in my 12 o'clock position and I'm facing his head from the top and I operate the right eye, for example, I see the same right eye without inverting. So, as if I was drawing. You understand what I say? If I'm going to operate the left eye and I'm on the top of his head there, I'm operating the left eye. I put the condensing contact lens there, and the image inverts. Actually, the lens inverts the image. I'm seeing the left eye like that. I'm seeing the left eye. So that's if it was drawing, understand? So I trained myself with that, so I don't use inverted at all. But I won't teach that to the residents and fellows because they have to learn. It's quite tough.
Yes.
I try to teach some, but they don't. They wanna do that, and it's good to do proprioception and keep the other patient's eye open so that you can see and to better examine the patient. Use a very good indentation. And I started using the Q-tip, but it's too large and broad and make some pain. But the small clips from the office, they help a lot more. And in this way, you can see the retinal periphery, doing depression, do the cryo, laser. And this is the chart. I guess this Sankara Neta, he's from India, I guess, no? I'm not sure. This name is...
That's when we are trained. I myself, Amit Jain, Jaydeep, we are all trained from there. And that is founded by Dr. Badrinath, who's the earliest fellow of Charles Stephens in 1970.
Wow.
So he came to India in 71 and then started getting the technology from America to India in 1971. And he started in 1978.
71, I was 2 years old. Yeah, a long time ago. So by drawing, you have to see what you are drawing. These are some clues and what to look at. This is interesting, you see. And this is just some examples. We are just going to the end. Just some examples of what you have to draw. You can draw. Actually, you have to wake this up on your mind and do very good and beautiful drawings here. As you see, I'm showing some examples. The hemorrhages, retinal breaks and holes and retinoschisis. You see lots of examples here. So I think it's a good thing to draw and to locate the breaks beforehand, before going to the OR. Otherwise, you might get into trouble. But it doesn't mean that you have to find all of them. But if you have a retinal detachment, you got to find the break. Dr. Lam and Dr. Deveni usually said, you gotta find the break. It doesn't matter what, unless you have some very hazy media, but you gotta find the break and the hole. You gotta try to search for it. And these drawings are interesting that they speak for themselves. When you take them to the OR and you see vitreous hemorrhage, you see opacities, you draw in green, and if you take the drawings to the OR, that might get, see the IOL inside, it's media opacity as well. It's being drawn there. You get your job easier if you have all these. So it's good. If you have the article, Natarajan, just send me the article and I'll be loving to see it and read it up and spread with our residents as well. So different ways of drawing here. As you see, pigment epithelial detachments, nevus, choroidal detachments. So I encourage you to draw exudates and gliosis deposits in the RPE. So the thing is, should we be doing scleral buckle more? I think so. And I have recently, I had 2 cases recently that is from 2 months now, when I performed this scleral buckle together with the vitrectomy. I was looking at the patient last week. We already removed his silicone oil. He was a high myopia, only eye patient. And the other eye had a surgery in another service, and the other eye doesn't actually see. And this eye that I operated on, he had this retinal detachment. We did vitrectomy with the buckle. I was looking at his retina, and the eye dentation was so good, Amit, that I was so happy to have done the buckle. His eye was white, beautiful. And if you see the buckle, some doctors, they advise you, no, don't do the buckle. Today is modernity. You got to do 23, 25, and otherwise you're going to get the eye reddish. The eye will be too red, and these things, I don't really think that way. And when I saw the retinotomy in the very retinal periphery that I did, temporal, and I saw the retinotomy there sitting on the buckle like that. The retinotomy was flat, and the buckle was like that, 90 degrees. As you can see here in my hand, it was 90 degrees. So the retinotomy, the very retinal periphery, had the support to be there without being just hanging there without any support. We had like a wall that was the buccal indentation. In that way, the retina remained attached, and that helped with the healing and so on. So that was about it, and I wanted to share this to you because I think what is most important for you and for us is to teach and to show something, but it's better, Amit, to tell a story. It's better to tell a story. Otherwise, people don't know. Okay, it's good that Hudson, he likes doing buccal, and he does buccal vitrectomy, and but to tell a story, it's a lot better than just showing what you like doing. It's good to know how things started from and why we learned and why we do some things different today. Don't you agree?
Correct, sir. I agree, sir.
What about you, Aishwarya?
Yes, sir,
Aishwarya. I'm still learning to pronounce your name, Aishwarya.
Sir, I have a doubt, if I may.
Sure.
Yeah, go ahead.
Sir, can you please tell me when is the right time to combine a vitrectomy and a buccal as opposed to doing just a buccal?
Yeah,
Like
the right
if you
time.
plan to do a buccal alone, when would you swoop in to do a vitrectomy? Like, take an on-the-table decision to do a vitrectomy when you've actually planned just to do a buccal?
Yeah, usually
Can I?
I'm gonna send you a paper on that. This is a paper we wrote back in 1998 in Toronto, Canada. But from this paper, many other papers were published with the same subject. So we kind of started this thing and these decisions. And if I want to do a buccal alone, it's a retinal detachment with no PVR, no tractions, clear vitreous, and you see the hole is usually if the detachment is very shallow and superior, for example, 12 o'clock or 1 or 2 or 3 o'clock, it's easy. You just go ahead and do this bubble of gas, and then you wait for the resorption of the subretinal fluid. But if the break is down below, it's like an infratemporal or infranasal, but even though the buccal doesn't, I mean not the buccal, the hole, even though the hole is not very large enough and does not have many tractions or no traction at all, and the vitreous is clear, as I said, it's better you do a buccal because the patient won't be sitting, staying upside down, so the gas wouldn't cover this area. But by doing the buccal, that are indicated in this situation is that the vitreous is clear, no haziness, the hole inferior, and 1 or 2 holes close. But if you have 1 hole up, 1 hole down, no problem. You still go ahead and do the buccal. And this would be a perfect case, and especially if the patient is phakic. Then I'll go ahead and do a buccal. And another thing, the vitreous in this situation, no haziness, and not very old retinal detachment, a recent retinal detachment, because the longer you wait, you might get possibility of getting more PVR and the redetachments, and the surgery may fail. But this is my indication for the buccal alone. But for buccal vitrectomy, when I do buccal vitrectomy, okay, go ahead, Amit.
So just for the benefit of the students who are attending, when we're talking of buccal with vitrectomy, there are two things. One is segmental buccal with vitrectomy, and one is encerclage band with vitrectomy. So what you are talking would means indications for both would be different. So you can proceed, sir. I just wanted to highlight that there are two different ways of seeing buccal. One is encerclage and one is segmental buccal.
Yeah, this I'm talking about the buccal with the whole thing, the encircling band, the 240 band, for example, and the buccal as well. I'm talking about the 240 band and 276. So I like using the circling band, so I put the buccal, the small piece of the buccal, wherever the retinal detachment is. So that's what I'm talking about. I don't usually suture only the buccal there. Could be a good idea, but in my technique, I like doing the encircling band and the buccal below. And moving to the vitrectomy, the indications for the combination of buccal with vitrectomy, I do that for pseudophakic and aphakic patients. That was the subject of our papers. And by doing that, as I mentioned previously, after you do the buccal, and in this case, I wouldn't put the 276, for example, the tire, this broader buccal. I would just go ahead and either do a 240 band around the eye or the 42 band, a larger one. But usually I can get away with that with only the 240 band as a tiny one. I put the 240 band around the eye, and then I do vitrectomy. And the combination of the buccal, I don't tighten the buccal right at the beginning of the surgery, just at the end, in order to avoid choroidals. But by putting the buccal, doing the vitrectomy, removing the vitreous with the RPE cells that could possibly cause the PVR, and cleaning up and getting the retina mobile, even opening more a break, or if it's irregular, for example, doing lasers inside, using PFC, attaching the retina from inside, and then at the end of the surgery, I would attach the band. I would have indentation. I don't need that much indentation. I would have some indentation. I will have the breaks closed, And then that's the case. That's the indication for me. But if the patient already has some detachment with PVR, of course, and then I will go ahead and do the combination. Hi, Jaydeep, would like to comment?
Hi, sir. So I just wanted to ask one question. So you combined vitrectomy with a 240 band or a 40 band, 42 band, or with a tire?
The
Most occasions.
combination vitrectomy and to 40 band.
Yeah. Do you combine it with a tire like a 276 or a 279, or you use
No,
the
no,
band?
no. If I do vitrectomy with the buccal, my buccal would be my buccal, will be the 240 band only, and I think that's enough. And then
Right,
I
right.
would treat the retina from inside, if necessary, vitrectomy, PFC, perfluorocarbon liquids, and remove the tractions around the break, or avoid any traction there, and do the complete vitrectomy. And then at the end, I would tighten a little bit, and then I would get indentation I need. So I wouldn't put
Oh,
because I don't think it's necessary. Because if you are doing the vitrectomy there, you already did the laser around the break or hole. Doesn't matter what size it is, or if it's here or there. If you already lasered the things, and if the break is round, you wouldn't probably not need laser. But I'm inside there, and I want to be safer, so I prefer to do the laser. And then
right.
I do the buccal in the very retinal periphery, so you shorten somehow the retina. I don't want to be too tight, so a little bit, and then the retina would stay attached. But then the
Yes, sir.
issue would be if there was too much PVR or not, whether you should end the case with gas or silicone oil, and then you decide.
Right,
But
sir.
I don't, as you said, as you asked, I don't put the buccal, the 276 or 277 or whatever
Right.
wedged thing, and
So, right.
below the 240.
So, like, I think we use most of the times this 240 band for most of vitrectomy surgeries for retinal detachment. Like I was trained at Shankanetla, and I'm sure Natarajan sir also uses the 240 band most of the times
Yes.
when he does a vitrectomy for RD surgery. So that is something which definitely helps, especially as you said in phakic eyes and a little bit of inferior PVR, where you or the PVD is difficult to induce up to the ora. In such circumstances, you would like to put this band and combine it with the vitrectomy. So
Yes, yes,
we
yes.
also prefer
Especially,
doing that. There
yeah,
are
I
certain
prefer is
occasions only when I use a tire like a 276 or a 279 along with it, where probably there is a large tear, especially inferior one, which is not completely supported on this 240 or 42 band. So then in that scenario, I would like to add a tire component there just to support that large tear, which is probably extending a little posterior in that scenario. Because if you put a 240 or a 42, it kind of opens the posterior end of this large tear, and that is how then sometimes recurrence in PVR occurs, inferior one especially.
is
Or
not
if in,
supported.
yeah, so that
Yeah,
scenario, I would like to put a 276 or a 279 to just a small piece with a single suture to cover that region. And otherwise, as you said, some complicated old PVR cases where phakic eyes, young patients without any PVD, especially children, sometimes it's very difficult to induce the PVD and take it up to the ora. And doing peripheral vitrectomy again is difficult. Lens touch is something which you want to avoid again. So then you can support it with a little broader buckle, probably a 276 inferiorly.
yeah, very good ideas. And I always try to avoid the lens whenever I can,
Right.
going from
One more
this
point
is
regarding Dr. Amit, as he said uh, about drainage, he prefers non-drainage, and as you said that I suppose you drain most of the times because you are doing laser after the drainage instead of the cryo, which I think something we can try doing, because I don't think most of us do that. That's a great idea. What I was doing is I used to do laser to the lesions which are in the attached retina, and then do cryo to the area where there is the detachment and put the buckle. But I prefer draining somehow. I don't know. I was at Shankar Nitla trained by Dr. Tarun Sharma, so I saw him draining most of his cases except the ones which were very shallow, as you said, and young patients with good RP function. Then you don't want to really go in for the drainage. But otherwise, I drain. But nowadays, when I'm not doing the cut down, I do a needle drainage with a 30 gauge needle or a 26 gauge needle directly through the sclera. Obviously, trying to avoid areas where you expect the vortex veins or larger vessels. So generally around the horizontal recti. That
Yeah,
is where I
I
prefer to
think
drain.
it's a good idea to cut out and separate the sclera. You go there towards the sclera, and you open up the area, the safe area, and then if necessary you cauterize it or not. But I think it's a good
I
idea, and
was
then you
I was doing that.
with a
Yeah,
very
correct.
tiny needle and drain it. I think it's good to drain. But if you drain, you should not tighten soon after you drain. You just
But I
have to
faced
wait for
some.
the fluid,
Mhm.
wait, wait for the fluid to
I
escape, and that
right, right.
works okay.
Some look. I had
So,
some experiences with suprachoroidal hemorrhages. With when I was doing the cut down, I
Uh,
always started with that first 5 years. I was doing the cut down. So, and the needle I was using was the 10-0 nylon, which we have that needle for draining through the cut down
mhm.
after doing cautery to the base or to the knuckle of the sclera. But I found that in my hands there was a little bit more cases of suprachoroidal or subretinal hemorrhage with that technique. So
Yes, yes. But
I
I
tried
don't
to do
like
something
using
different.
the nylon today, nylon, because sometimes the patient feel, even though the nylon is hidden, but sometimes if I have to suture, when I do
Uh,
the buccal suture, I use the Mercilin or Dacron
no, no,
five
not
volt.
the suture. I was talking about use the needle. You use 30 gauge needle for draining, right?
Ah, okay, okay, okay. The
So
needle.
instead of
Yeah, yeah.
that, the tip of 10-0 nylon suture needle, that needle I was
Ah,
using
good
for
idea.
draining.
Good idea. Yeah,
It's quite
it's
thin,
very
so
tiny.
yeah. So that just puncture the knuckle with that. So in Shankar Netralaya, I think this was what we were doing. I think Amit must have seen the same. So I
Yes,
think even
but
yeah,
Dr.
I,
before
Natarajan is
before doing
using
the
same.
puncture, I like to open the sclera, to keep
yeah,
this area, so safe area, so that I will puncture safer. I wouldn't puncture without, uh, opening,
Blindly,
during the
blindly.
slit,
Correct, correct.
separating the edges, and then will be a lot safer. But good ideas, very good ideas.
so I
Congratulations.
always drain. So I
Yeah.
always
So
drain and adjust the buckle. Amit wants to
I
say something. I think
I want to
finally you have
drain
to
all the time.
master the, no,
But
finally you have to
Natarajan,
master. Yes,
you should
yes,
encourage the residents and fellows to do the laser after drainage. Wait for
yes,
a while until the fluid resorbs or comes out, and then you put the indirect with the laser,
yeah,
you know,
right.
and then you do the laser around the break. It's so good. You
Yeah,
sleep
sounds really
well,
good.
as Amit said. You should sleep well.
As
You
good
wake
as
up.
vitrectomy. It is as good as a vitrectomy
Amit
when you
Yeah.
wants
go
to
to
say
sleep.
something. Yes, Amit.
As Hudson sir told that everything has a story seems better. So basically this started, my non-drainage attempt started when post-fellowship when I was out of Shankar Netralaya. In my first,
Oh, sorry.
am I audible?
Now,
Hello?
now
Yes,
it's okay. Now it's okay.
now it's okay.
As Hudson sir told that a story helps better to understand. So when I was post fellowship, my first 4-5 cases of buccal, I tried drainage in those, and out of those 2 cases one had subretinal hemorrhage and one had an incarceration. Subsequently, I was apprehensive to do drainage for the next 2-3 cases. So I tried non-drainage technique, and it did very well. Now I have almost done more than 50 cases, and of which 48 or 49 are non-drainage. I just select my cases. I don't do each and every case as a buccal or a drainage procedure, but whichever cases I have decided to do a non-drainage, it has given a good result to me. So it takes a less time. It's like it doesn't feel also like you're doing an actual surgery, because you just go open, put an encerclage and put 1 or 2 sutures of buccal, and you have to close it again. I agree, drainage makes us feel better. The second point I wanted to put was, I also do laser post-op, but I usually do on day 2, post-op day 1 or day 2, around the breaks, because in the intra when I'm doing non-drainage, the fluid is there. But as 1 or 2 day passes, the retina flattens, and then I add laser. Also for my good sleep of the next day, because cryo will take 14 days to have its major effect, versus laser will have immediately on the 1 or 2 days, and maximum effect will come in a week. So I agree with Dr. Hudson that laser is a good idea.
Okay,
So
and another thing,
I think the take-home lesson for a resident is, I think Charles Keepens mentioned always, do the least, get the retina attached for any detachment. So I think, again, this is what I learned from Dr. Vadranath, who was trained by Keepens. And I have met Keepens also. He's come to the clinic in '93 in Mumbai. And so I think the one lesson to every retina fellow and resident is, I think you should learn the best from every teacher. And finally, I think you should see what is good in your hands. As Dr. Jaydeep said, in my hands, I think that's important. And that is why I actually wanted to make a presentation, which I'll probably make it in the next 2nd or 3rd class. The last chapter of Steve Charles' book, Surgical Self-Education, which says, first you have to equip yourself with knowledge, experience. And this
I want to watch
learning.
this. I want to watch this lecture. This is going to be amazing. Yeah.
Yes,
don't forget to spread the link for us.
Sir, I remember making that presentation for you, sir, in 2007 or 8, I believe.
No, that is a presentation today. Me and Aishwarya was searching. I'm searching for that presentation.
I hope I have it somewhere with me, because
no, it is there in the cloud. Yeah, somehow I'm not able to get it. Otherwise, you have to.
It's one of the most. Although I was still in my residency, but that chapter is, I think, the first chapter you should read before you do VR surgery.
Right. That's what I thought. Today I'll give a talk and record it, but somehow I couldn't get the slides. Maybe we both can search it. Yeah, great, Hudson. Sure. You have anything more now, or you want next week?
No, I wanna ask Aishwarya. Aishwarya, she didn't speak much. What do you think? What did you think, Aishwarya? You are doing more buckles today, more vitrectomy.
It was very nice lecture, sir. Thank you so much. I was actually listening to all the points by all the teachers in this panel, and trying to understand whatever I could.
So
Aishwarya, they're actually coming to the hospital tomorrow to meet all of us. And in the meantime, she just finished her residency about 2 months back. And I think she's in the juncture. So that's how I thought this can be a thing for many fellows and residents who don't work now. And I'm glad you created the time. So I'm happy Aishwarya also picked up to at least listen now. I still don't find residents are all worried during this time. Fellows are worried during the COVID time in India, and they're wondering how to live and how to survive instead of learning. So I'm happy we are creating an environment for learning. I'm glad she's there.
Thank you very much, Natarajan. It's so good for me to interact with you, because I had many mentors. I have many mentors, retina professors, and so I have the ideas from all of them. And then I created mine. And that's the thing to go. Otherwise, you would be doing the same thing And no, I don't know what to do now. And but Natarajan said I should do this now. This is the complication that I got, and I have to get away with that by doing this technique, the other technique. So it's very good to know how people do around the world, and many different thoughts and things. And as I was saying, the laser is something we commonly do here, but some people don't do. But still we use cryo. Some people don't. You prefer to do the thing, the laser 2 days later. Maybe I prefer to do right away, and so I would use a band or a radio band or not, or a radio element or a 277 or 42 abroad, this and that. So these things we learn, So it's an honor for me to be here, and because we are discussing these things, we also learn again. We revise, we review the things, and we discuss, and we try somewhat help you as well, and it's very good to interact with you. It's an honor
Yes,
for
sir.
me.
Yes, sir.
You want to say
So
something?
I had a question, sir. Actually, I had a case. If there's a pseudophakic inferior retinal detachment where you can not visualize the break, but as per the Linkoff's law, you think that the break should be here. So, would it be right to go with a buckle in such cases, or do a vitrectomy because you have not been able to visualize the break?
If you are not able to visualize the break, and you can go ahead and do a vitrectomy straight, because you might not have seen this break, or might be a very tiny little break. And so by doing the vitrectomy, you might do the laser in some places there, like inferior, you do some laser, just a tiny line to protect, and then you could do supratemporal, infratemporal, and supranasal, and also where the infusion line is. Otherwise, you wouldn't get the break if it was there. So you could go ahead straight with the vitrectomy, remove the vitreous, and then do some laser where you thought the break could be, the position of the break. So I would do the vitrectomy straight in this case. Otherwise,
How about if it's an inferior RT with a slight fluid slightly higher up on that side, so we know that the break should be somewhere here around as per the Linkoff's rule, and then place a buckle there, and just a buckle, not a vitrectomy. I had a similar case, and I decided to do a vitrectomy or do a buckle based on assuming that the break would be where as per the Linkoff's rule. And luckily for me, the case settled, but I was not sure if I did the right thing or not. Should I have gone for a vitrectomy or not? So I just wanted your opinion for the same.
This case, if the patient was pseudophakic or phakic, then I would go straight ahead and do vitrectomy. But if he's phakic and the mid is clear, and you don't actually you have the detachment, but you don't have the PVR, and the retina detachment, the retinal detachment is inferior, then I will go ahead and do the scleral buckle, even though I don't see the break, because after drainage, and then I would drain in the surgery. I would probably see the indentation, and then I would see the break there. But if I didn't see the break, because I know the retinal detachment is inferior, then I would do some cryo in the inferior part, even if I didn't drain. I would do some cryo, I do the buccal, and I would do the buccal first if the patient was phakic. But if the patient was pseudophakic or phakic, then I would go ahead straight and do the vitrectomy.
Okay.
So Asta, I think you can, if you don't have vitrectomy option available with you, then this can work fine. If you have no option and the patient, you are the only person who knows how to do a buckle around and no vitrectomy available, you can go ahead with it. But anyways, in case you really feel like you want to do a buckle in such a scenario, then you can do a end-to-end buckle. So what is end-to-end buckle is nothing but you see the extent of the SRF in the aura, and you cover the entire area of detachment with the buckle and do cryo to that entire area. Probably while doing cryo, you might notice a break, and then you are confident.
Huge buckle and huge, almost like a 180 approximately.
That's
use
what.
buckle and
So
use cryo.
if you really want to be sure and you want to do buckle, otherwise where will you place when you don't know where the break is? How will you decide? So if you want to be sure, you do a end-to-end buckle, that is cover the entire area of retinal detachment at the ora, that is, and do cryo to that entire region. And in case you find a break while doing the cryo, good enough, you can decide you put the buckle there, because you do cryo before putting the buckle. So you can first do a cryo and check where the break is. If you still can't find it, then
Yes,
put
yes,
the
yes.
buckle end to end, and then cover it with the obviously you will put the 240 band along with it, and check the entire periphery elsewhere also to make sure there are no other breaks. And sometimes there can be a break superiorly which can have a tract, and inferior detachment might be there, while whereas the break is somewhere in the superior quadrant with a tract. So that is also a possibility. So look for that. And
Yeah,
drainage,
very good
yes,
ideas.
that's the case.
I wouldn't
You
do
look for drainage.
that much cryo. I would do just some economic cryo, some cryo below, some cryo here and there. But I would do, because the cryo, after you are doing the cryo, the break might pop up, and you see in the middle of the cryo, you see the break there. I've
Yeah,
seen these images. It's interesting to see. I don't
yeah,
know
yeah.
if we have available videos on that, but Natarajan would be great to see, cryo, and you're doing the cryo and the break showing, popping up there. It's interesting. Actually, I have a video on cryotherapy, and I'll share with you later. I will share this with you. I have to download it down to this computer here, and I will share this video to you. It's very interesting.
I'm happy we have created some time for the residents and fellows every week. So we will see you next week, Tuesday.
Thank you
Yes.
very
Right?
much for
Thank you.
interacting
Yes.
with me. Thank you, Ashwara, Amit,
Thank you, sir. Thank you so much.
Jaydeep,
Thank you,
Thank you,
sir.
sir.
Professor Natarajan. Always honored to be here. And yeah, Amit.
Only one
I mean,
doubt.
Thank
The
you, sir.
painting behind seems to be retinal vessels or some tree.
just a second. You're
Dr.
already
Hudson.
taken over.
This painting. This is
Yeah.
very beautiful. This is Portland, United States. Uh,
It looks like
my
retinal vessels.
Yeah, it looks like retinal vessels. My partner that works with me, Dr. Fernando Verissimo Pacheco, it's a picture actually. He was in Portland, and he makes pictures. He's a photographer as well. He's a ophthalmologist, general ophthalmologist. He does plastics and everything but retina. And this is from him. I love this. Just a moment, just a moment. See, you see better now. It's shining.
Yes. So where is
Okay.
Daniel today? Where is Daniel?
Daniel is sleeping. It's
Sleeping. Okay.
8 because
I just
he
saw
slept.
Jaydeep's son was there. And
Yeah.
Amit, you actually,
My son
Amit?
is putting one of the microphones in his ear and listening to Dr. Hudson.
Young
Oh yeah.
ophthalmologist.
I was watching him. He was plugging and unplugging the thing in our ear. He's very funny.
So
Yes,
Jaydeep
sir.
sir is Dr. Jaydeep is
He's-
smart. He's teaching him buckle immediately.
He's
No,
ready.
actually,
He's
yeah,
not practicing.
Jaydeep, yeah, Jaydeep. He was removing the earphone. He's
Yes.
very happy, no? He was.
He
He's the
wanted
next
to be
buckler.
seen.
And Asta has got a twins. She's got a 1.5-year-old twins.
Yes.
All right.
Okay.
Take care, sir.
Yeah.
Thank you.
Thank you.
Thanks a lot.
Thank you. Thank you.
Thank you. Thank you very
Thank
much,
you, sir.
sir. Very
Thank
nice.
you, everyone. Thank you, Dr. Hudson. Thank you, sir.
Pleasure is all mine. Thanks a lot.
Thank you.
Thank you. Thank you, Dr. Hudson.
Bye-bye.
Dr. Hudson.
Bye, sir.
Damit, sir.
See you.